Let's discuss acute abdomen in our series of case discussions. And what does this acute abdomen mean? Now, look at this case scenario. A lady of 40 years coming to the accident and emergency with severe abdominal pain. Now, in acute abdomen, it's a bit of a bit of a descriptive term. It doesn't indicate a diagnosis, but it embraces a lot of acute pathologies which can happen in the abdomen. And as we know, most of the acute presentations, the presentation is pain. And if it's an acute, it has to be a acute pain, that is a short durated pain. And in most of the cases, they have a some form of increased severity. Either it may be very severe pain or it may be at least moderate pain, because if it's a mild pain, a person wouldn't rush to the emergency. And so this most of the time people coming with this sudden onset severe pains coming to the casualty, we label them as acute abdomen. So just let's think what are the possible pathologies that can present as an acute abdomen. So it's better to have a piece of paper and a pen and just write. I'll give you about half a minute. Write the pathologies, pathological conditions that can present as an acute abdomen, the main pathological entities. You can pause the video for a while if you want to take a bit of more time to think and write the pathologies. So, but anyway, let's see on screen and see what pathological entities can present as acute abdomen. The commonest cause that we see is inflammatory problems. And inflammation, majority of the inflammations presenting in the abdomen are secondary to infections, mostly again bacterial infections. But sometimes you have things like acute pancreatitis, where at the beginning it's just a chemical induced inflammation. So inflammatory pathologies, and also the inflammatory pathologies may be restricted to one part of the abdomen. Most of the time the onset is like that, like say like acute appendicitis or acute cholecystitis, acute pyelonephritis. It is the inflammation is limited, or it is actually confined by body's defense mechanisms to that particular region only, like the momentum, everything will come and try to block it from the balance of the abdomen. So localized inflammation like what we describe are the most common. But sometimes you have inflammatory problems involving the entire abdomen, which we call a generalized peritonitis, like a perforated peptic ulcer or perforated appendix. So, for that matter, a perforation of any hollow viscous, like maybe a diverticule abscess has ruptured. And but as I said, most of the time they start with in one region, but because it is severe, before body could can get them localized, it gets more generalized. So of course you will agree with me, the generalized forms of peritonitis are more severe and serious, and they're actually more life threatening than localized inflammation. So that is something commonly we see. Then the obstructive pathologies, any hollow viscous getting obstructed, again presents with acute abdominal pain, like the cystic duct can obstruct biliary colic, and the ureter, the ureteric colic, or the intestine can get obstructed. So obstructive pathologies. Then it could be due to a bleeding, like a perforated aortic aneurysm or a ruptured ectopic pregnancy, bleeding. Ischemia. If part of bowel undergoes ischemia, it also causes acute pain. We know anywhere in the body, if a part gets ischemic, like a myocardial infarct or a gangrene of a leg, it causes a severe pain. The last one is trauma. After trauma, people can come present with acute abdomen. But when you if you revisit your lectures or information on trauma to abdomen, the cause for pain in case of trauma are related if there's intraperitoneal bleeding, or if the trauma causes a viscous perforation and leads to inflammatory response. Those are the causes of pain after trauma. Of course, due to the injury, the person can have some pain, but a more generalized pain can are usually secondary to these two. But trauma is considered differently because it's actually a different entity of the mechanism of the problem. But trauma I will not discuss in this further because it's very obvious, and of course we can do in our trauma discussions that I do in the ward during the appointment. So these are the pathological varieties. I'm sure most of you, maybe all of you, got these entities listed. So how am I going to make the diagnosis? So like this, the lady I was speaking earlier, she complained of a severe pain. Just started this morning, severe pain. So it could be one of these. So how are we going to make the diagnosis? And as usual, it has to go through uh, the steps of history, uh, say the history, examination, investigations. But just one thing I want to show you now, the conditions we listed, the inflammatory and the bleeding, uh, they are very familiar conditions to us. But what are the causes which can cause ischemia in the abdominal cavity? So again, I'll give you a couple of minutes. Maybe best thing that you can pause the video and list what are the conditions that can lead to ischemia in the in the abdomen. What are the conditions can lead to ischemia in the abdomen? So pause the video, right, and then replay and just see whether you have got what I am listing here. Now, even looking at this diagram, now as in any other part like a myocardial ischemia or your acute limb ischemias, obviously, if your mesenteric vessels either going to the colon or maybe coming, now this part is actually the part that part of the small intestine, that part is removed here, but you can see the small intestine mesentery here. So if a small intestine vessel, so any of these vessels can get obstructed. Now even the celiac axis, the leg supplying the stomach, they can get obstructed. So if you have primary vascular pathology like any other else, your gut vessels can get obliterated by atherosclerosis and they can get ischemia. But this is not very common like in your myocardial ischemia or leg ischemia because there's a very good the collaterals developing because the intestinal supply is interconnected so much. It's not very common, but it can happen. So one thing is any obstruction of the vessels itself, or other the most common reason why they go into ischemia is if any strangulation of the vessels occur by external compression, like say like the sigmoid, it can undergo a volvulus and the vessels twist and you get stomach can undergo volvulus, and testis, the torsion of the testis, and sometimes the testicular pain, sometimes it may be felt in the abdomen. And of course, if it's an undescent testis, then of course it will be definitely intra-abdominal pain. Or if you have a hernia, where bowel goes in and gets obstructed. It may be external hernia where the diagnosis is straightforward, or sometimes internal hernias happen. Maybe something has gone through a band and it causes this ischemia. So these are the causes. I'm sure that also you also have listed. So mesenteric obstruction may be due to a thrombosis or embolism. Then volvulus due to uh, twisting around a mesentery, and then strangulation of bowel due to hernia, external hernia or internal bands, and of course the torsion of testis. So all this should be kept in mind when you are evaluating a patient. because in the history and examination this has to be kept in mind. Like say examine the scrotum for absent testis, otherwise you may miss a diagnosis, and which the results may be disastrous if you make a mistake. So but anyway, so what are the important things in the history? So uh, in order to come to the diagnosis, like this lady who has presented with this acute abdominal pain, what are the important things in the history? I'll suggest that you we have done some discussions and with some key how to take the history. So you have with initial questions you make formulate a differential diagnosis, and then you take the various different questions that will help you to come to the conclusion. So pause the video and just write down. Okay, these are things that I'll ask and which will lead to the diagnosis. One thing of the organ involved, and the second thing is what is the pathology? Is it a inflammatory, or is it obstruction, or is bleeding, or any form of ischemia? So I'm sure. So pause the video, right, and then have a look. So I'm sure you would have written most of them. Duration is of course definitely important to say that's in acute pathology, and also sometimes you may have a chronic illness for some time and it becomes acute. That's also very important. Say you have a dyspeptic symptoms for a long time, and recently the person takes some NSAIDs and gets a sudden epigastric pain, and now it's more generalized. He's very ill. So you have your priority diagnosis is going to be a perforated peptic ulcer, or somebody has intermittent dyspeptic pain, now has a severe epigastric pain radiated to the scapula. Otherwise patient looks okay, you may think is a biliary colic. Or person who gets repeated epigastric pains now has a sudden pain and radiated to back, so pancreatitis. So like that, the duration is important. One thing is to diagnose an acute current problem. There should be acute exacerbation or just acute onset where the person was previously well, or with a background history of some pain, things gets acute. So very important the duration. And then as I said, to tell the to mention the know the how bad it is, the severity is important. So in acute abdomen, majority will have a moderate to severe pain. Now, generally, severity will it point to some pathology? Yes, because obstructions cause severe pain. The colics are very severe, and also the ischemic pains are also very severe. But in contrast, the inflammatory pains are not that severe. And at the beginning, they will maybe just mild and then building up to moderate levels. What about bleeding? Of course, bleeding also can cause some severe pain, but uh, now it may be not as severe as a colic or ischemia. But one thing we have to remember, so like a aortic aneurysm perforate in the leaking phase, they will have severe pain, and then also like ectopic, they can have pretty much of severe pain because of the rupture suddenly causes a pain. So, but anyway, severity is important, and then so that's the thing. Site. Now we said to one the key to diagnosis of organ involved is a site. So you know if it's a upper abdominal pain, you will be thinking of all these upper abdominal organs. But if it's a person localized to right hypochondrium, you can more get the organ list less. But if it's epigastric pain, it is a epigastric organ, but it could be even the gallbladder pie because it's a foregut structure, and we have to keep this first thing of referred pain when we are analyzing the site. So site will give will allow you to reduce your to few organs. Now, so supposing the person says, "Okay, I have pain everywhere in the abdomen," so it means a generalized pain. But you ask, "Okay, but can you remember where it started?" Okay, they may say, "Okay, it was epigastric," so it could be a perforated peptic ulcer. But sometimes acute hemorrhagic pancreatitis also, it's initially epigastric, but it can spread to the other things, other parts. And also another thing to localize organs is there any functional disturbance, like if any abdominal organ involving causes a functional problem, that will help. Say like jaundice, it may indicate a problem in the liver, or the bile duct inflammation, cholangitis, or So like, and then also our inlet outlet symptoms. That is, if you're in hollow viscera, if it is connected to inlet outlet, that is of course like the mouth or the anus or the urinary tract, then say like you have a hematuria, so it indicates a renal pathology, or person vomits a lot. So it may be because any intraabdominal pathology, they may be a bit nauseated, but if they have a continuous persistent vomiting with central colicky pain, then of course you know the bowel is obstructed, or constipation for that matter. Or in the history, the person has a bleeding history, bleeding per rectum. Now he gets distended and colics. It may be a sigmoid tumor which is getting obstructed. So these functional things and uh, functional and inlet out symptoms are important. And then one thing, of course, definitely yes, at the beginning, so these functional things and inlet outlet symptoms will help you to with the site to reduce the organ involved. But now for the pathology, so that's another thing. So the diagnosis is an organ and a pathology. So nature, the site and functional and inlet outlet symptoms will help you to localize the organ. But to say with it's a type of pathology, it's inflammatory or obstructive, ischemic or bleeding, nature of pain is important. The main thing is whether it's a persistent or a colic. If it's persistent, it's likely to be an inflammatory pathology, or could be ischemic, or it could be bleeding. But if it's colicky, it just comes and stops and comes back, you know something is getting obstructed. But keep in mind, like biliary colic, sometimes it may last for longer durations. And then radiations, because there are typical radiations like the pancreatitis or biliary colic or your ureteric colic, they will help you to clinch the diagnosis. And relieving and aggravating factors also will help, like bending forwards help relieving in the acute pancreatitis. So with these the quick analysis, the main aim should be to find the organ involved and the type of pathology. So for organ involved, as I said, the site, functional disturbances, inlet outlet symptoms will help. The pathology will be other characteristics of pain you will be able to find. And also if you are suspecting inflammatory pathology, fever is important. But of course the history should cover all systemic inquiry, because say like pancreatitis, it is a multi, it can affect other systems, so like breathing difficulty, circulation, everything. The good systemic but quick is important. And your other parts, things on the history also important, like say a person who is on NSAIDs, it may be the cause for the gastric ulcer and perforation. So past medical history, drug history, your social history, if it's alcoholic, it may be very well could be a pancreatitis. Now, so smoker, is it got ischemia? So likewise, so all parts of the history are important. One thing, it may give clues to the diagnosis. Another thing is to treat the patient as whole. All this is important. And then examination. Now examination, again for each, just think. Now with your history, now you have come to a diagnosis. Say okay, you think okay, this is a peptic ulcer, or you think it's a acute pancreatitis, or you think it's a biliary colic, something. So with the history in acute pathology, most of the time you can come to a diagnosis with some certainty, because these are, as I discussed in previous discussions, the acute pathologies, the characteristics outstand, so it's easy to catch. So with this in mind only you examine. So you have to think, okay, but now what are the physical signs which will further confirm my diagnosis? So like if you're diagnosed, say like acute cholecystitis, so you know Murphy's has to be there, fever could be there. So likewise, but of course we evaluate in a general manner. So inflammatory pathologies, all the generally what are the things that you are going to look? Say like fever, or in bleeding, pallor, and also of course you have to see whether how comfortable the patient is seeking looks very ill. So then of course something like bleeding and ischemia are more likely, or a severe inflammation like acute hemorrhagic pancreatitis. So general examination is important. and then your cardiovascular respiratory are very important, because these are acute pathologies, and they may be compromised. As I said, if the patient looks very ill, of course, first, even before take the history, maybe that you will do your ABC and start some form of resuscitation, may move to the ICU quickly. So this is a bit of a balance of everything you do, but I'm taking in order just to make the diagnosis thing easy. But of course, you have to keep this in your back of your mind. So then, of course, your diagnostic things will be mostly in the abdomen and inspection. So anything, there may be some distension, but it will be marked in bowel obstruction. So if you see a big lot of distension, you wonder with the obstruction, and then look for any visible peristalsis, and also past surgical scars, because it may be a obstruction due to adhesions. And also just look at the hernial orifices if there's any obvious swelling. And one thing, because I came to this point, one thing you have to remember is, say, like, you have somebody has a direct inguinal hernia, the chance of it causing obstruction is also very low. But of course, he gets obstructed due to something else, like a CA sigmoid obstructs, and due to the intra-abdominal pressure, this hernia gets prominent, and also it won't get reduced easily. But how now, how it's a bit of a catch. How am I going to know whether it's a the hernia caused obstruction, or the the intra-abdominal obstruction just let the hernia to pop out? Just on examination, if the hernia is the cause, it will be very painful and very tender. But it's just the pressure getting relieved, it won't be painful if that's over the hernia, and it won't be tender. So it's just a point. So so inspection, then palpation. Palpation, of course, you have to look for any organomegaly, those things. But main important thing in acute abdomen to look for tenderness, because if there is tenderness, it is indicative of significant tenderness is characteristic of inflammation. And whether it's a localized inflammation or generalized, if you have localized right hypochondrial tenderness and check for Murphy's plus, then you're telling, okay, it is acute cholecystitis, or RAF tenderness, uh, it's a appendicitis. But if you have generalized tenderness, then of course you have to think of a generalized peritonitis. Now, in other cases, won't you have tenderness, obstruction? Initially, there won't be a significant tenderness, but a person who is obstructed has tenderness in some particular area. You have to be very uh, cautious. It's a warning that that particular part, its tender, is getting ischemic, and going now the obstruction is going to get complicated by ischemia at that part, and that segment will perforate soon, and then will lead to a generalized peritonitis on top of the obstruction. Say, like, you have a CA sigmoid obstructing your large bowel, and with your large bowel getting distended and distended, if the ileocecal valve is competent, not allowing the back pressure to go into the small intestine, your cecum will distend a lot, and the cecum get ischemic, and it can perforate. And so, remember, in a person with a obstructed uh, rectosigmoid tumor, if your right eye left was a tenderness, cecal tenderness, that means you have to treat them early. So in obstruction, tenderness coming up, it doesn't come soon, coming later, it is a sign that there's a strangulation there. It's getting ischemic, and uh, will tell you that very urgent expiration may be necessary. Bleeding, again, there will be some form of tenderness. It may not be severe as this. Ischemia, now gut ischemia. Now, if it's a like primary gut ischemia, like a mesenteric thrombosis, now initially patient will have severe pain, and they look very ill, sweating, just like a myocardial infarction. You know that. But at the beginning, when you feel the abdomen may be not distended. There may be no significant tenderness. But later, with ischemia, if it's not treated, bowel gets gangrene. Then, of course, you get this abdominal signs become a marked severe distension, and then localized tenderness initially. If the bowel perforate, of course, it becomes generalized tenderness. But remember, if the abdomen is tender, don't disregard this. Right? The tender means something radically wrong. Then trauma I'm not discussing. So with examination you can confirm your original diagnosis. And also, so that's palpation, percussion. Now when is going to percussion be important? Now that is mainly important if you are suspecting a perforation of a viscous, because with the perforation, as I discussed earlier in one of the discussions, the diagnostic physical sign of a perforation is absent or obliterated liver dullness. Just percuss your tummy and see. In this most of the part you get a resonance, but under the right rib cage over the liver it is dull. But if you have free perforation, the gas will get into the peritoneal cavity and it will go over the liver, between the liver and the diaphragm and the rib cage, and so you get this physical sign of absent liver dullness, or some people call it impaired or obliterated liver dullness. So it's diagnostic of a perforation. Auscultation, again, it is important because in these inflammatory problems and maybe bleeding and ischemia, there may be a diminished vowel sounds and obstruction. It will get exaggerated. So it's a good thing to do this. And your other examinations are important. Like if you suspect it as a, could always don't forget to examine the hernial orifices, keeping what I told earlier in your mind, and examine the scrotum. You can't miss undescended testis or a total testis. Do a rectal examination, because if it's a bowel obstruction, you feel get this find a empty rectum. So with your history and the examination, it is possible to know what organ is involved, and out of these pathologies, what is the cause. So you can make a confident uh, clinical diagnosis. So, but as a good exercise, now just think of various situations. Like, say, somebody comes with a severe upper abdominal pain, or someone comes with a severe lower abdominal pain, or someone comes with, you can just classify maybe right hypochondrial pain, epigastric pain, loin pain, uh, left iliac fossa pain, right iliac fossa pain. Like that, you can just rehearse this. So, what in these types? What are the possible organs? What are the possible pathologies? Any of these first acute pathologies are possible, and in the history and examination, how I'm going to diagnose. Just to illustrate an example, say somebody comes with the left iliac fossa pain for one day. It is a moderate pain. So what are the organs there? Of course, you have your sigmoid colon, the urethra is there, and in a female, of course, you have to think of the gynecological pathologies also. So these are the organs, and then of course you just see whether it's a persistent or a colicky pain. If it's a colic, of course, you wonder if it's a ureteric colic with typical radiation. You ask urinary symptoms, and so that is a path to diagnose. But if this it's a persistent pain, it could be a diverticulitis of the sigmoid, or it could be in a female bearing age group is ectopic pregnancy, or it is an inflammatory problem of the tubovarian structures. So the persistent, these are possible, but of course it could be a sigmoid ischemia, but in that case the pain will be very severe. And then any inlet outlet symptoms, supposing the person had some constipation in the beginning, some episodes of bleeding, okay, then of course a colonic pathology is possible. So it may be a diverticulitis, or of course it could be a carcinoma of the sigmoid. Now it is maybe has some localized perforation, now has a persistent pain. So like that, you can actually play around with the different areas and think of differential diagnosis, and it's a good exercise. So when you meet a patient, your brain is it's already, your brain has rehearsed this, and it things will start, your reflexes will open up, and very easy diagnosis. And then of course your balance of these is important. Now coming back to the case we were discussing, left iliac fossa pain, okay, you think the person had a persistent pain for 2-3 days, now it's getting gradually more, and okay, you are thinking whether it's a diverticulitis, he had some bowel things earlier, and for the past also he had been getting bit discomfort in the left iliac fossa, okay, and he has fever. So okay, you know it's a diverticulitis, and you examine febrile. He's not pale, so malignancy bit unlikely, but you can never say no. Cardiovascular respiratory examination, abdomen, slight distension, and left iliac fossa has a severe tenderness. Okay, so you are confirmed there's inflammatory pathology in the left iliac fossa. So it may be diverticulitis, may be rarely a tumor getting localized perforation. Female could be a tube ovarian abscess. But of course, if they have bowel symptoms, you think, okay, most likely diagnosis is a diverticular disease. But you never know that there may be a person with diverticular history, but now the lady is having a tube ovarian abscess. So these things uh, here and there. So, but of course, you can make to a certain extent what is the most likely, and then next probably this, and most of the other things like a ureteric colic you can exclude. Anyway, so coming now, we have done our history and examination, and then we have to do some investigations to confirm the diagnosis. In a general manner, we'll discuss, and then we'll sort of again concentrate on what we're discussing the diverticulitis, what thing. So just pause the video and write few investigations that you would do to confirm your diagnosis. It's better to have an interaction rather than just listening to a lecture, and then you can test your competence, your knowledge base, with your more than the knowledge base, or I know all of you have a good knowledge, whether you are applying with a sense. So better to write the investigation that will be helpful in a general manner, and from one case we can pick up, and then you can rehearse for other conditions what are the useful things. Okay, so then, like full blood count and CRP, yes, of course it can. It is. It will not be diagnostic of a particular condition, but if you have a high neutrophil leukocytosis, a high CRP, like to be a bacterial infection. Of course, there are hematological tests which may be diagnostic, like serum amylase. In your history suggestive of acute pancreatitis, you do the serum amylase. But in this case, we discussed last the diverticulitis. You are not going to order serum amylase. Then liver functions. Of course, yes, if you are thinking of hepatitis or some cholangitis, that is important. And if you suspect a urinary tract problem, urinary colic, yes, if there are red cells in the urine, it will help to build up. Plain X-ray, yes, like in a bowel, if your main first differential diagnosis is bowel obstruction, get a plain X-ray, and it will help you to see whether it's a small bowel or large bowel obstruction. So, plain X-ray is also important. Urinary colic, it may show a stone, but now of course the investigation orders, of course it depends all on your resources are changing, but still our country the X-ray GUT still is being very commonly used for urinary colic. And of course these imaging ultrasound and CT are very helpful because they will able to locate, see the organs with more detail, and give you a different diagnosis. Even if you have think acute pancreatitis confirmed by serum amylase, still you will do a ultrasound, and maybe in severe cases a CT. Now say like the case we discussed, diverticulitis. Now these will give some clue to the, say there's a bacterial infection going on, but of course to confirm, uh, one will have to do a ultrasound or a CT. Of course, CT gives a much better diagnostic information. But of course, if CTs, you don't have facilities for CTs, there are some hospitals which you can't get an urgent CT, not available. Some hospitals, still there are some hospitals without CT. But of course, ultrasound is it's good in most of these acute abdominal pathologies to come to the preliminary diagnosis what you have come with your history and examination. Ultrasound, most of the acute pathology, if you think organ by organ, it will one thing confirm the organ, and also it can give evidence to what pathology is obstructive or inflammatory pathology, and also complications like abscess formation, everything you can see. Now, what are the role of endoscopy in this acute presentation? Not very high, because if you think like from top to bottom, now you're in a perfect peptic ulcer. I mean, you're not going to do an endoscopy. You get X-ray abdomen, see gas under the diaphragm, and you'll operate. Other conditions, say like you think of diverticulitis or ulcerative colitis with a toxic megacolon. You're not going to do a colonoscopy in the acute phase because there's a high risk of perforation. So toxic megacolon, X-ray is diagnostic actually. But if you see, you think you want to get more information, you may do a CT. Like again, diverticulitis, divertical abscess, you're going to do a CT. So endoscopies are not very helpful, but of course, say like if you're thinking of a bleed, a GI bleed, then of course endoscopies are necessary. A person coming with acute abdomen, uh, you can refer to one I discussed on ruptured aortic aneurysm. But initially, they also we did ultrasound, excluded a free peritoneal bleed, and then uh, if there's no free peritoneal bleed, of course you have to do the endoscopies and check mm, for a concealed GI bleed. So investigations, that's your thought process, and then treatment. Again, in a general manner, uh, list the things in the treatment. Now, pause the video, write a treatment protocol applicable to all of the pathologies that we discussed, and then from case to by case you can apply what are more appropriate. So write down, take time, write down, and then open the video, and then just check your background knowledge, whether you will be a safe doctor one day. As they are critical ill people, consider whether they need resuscitation. Before even you make the diagnosis, as I discussed earlier, you may have to do a airway breathing circulation disability and start appropriate resuscitation, and also monitoring is very important. So they may need either HD or ICU. And then, do they need any symptomatic treatment because they are very ill? Like, okay, acute pancreatitis, yes, your first one important thing is to give your analgesics, opioid, and also with the antipyretics are necessary. And any, do you need any specific pharmacological therapy? Acute cholecystitis, or you think it's a pyelonephritis or a cystitis, tuberous abscess, or even diverticulitis, maybe divertical abscess. You have to start on IV antibiotics. And very important, fluids nutrition. Now, some pathologies persons may be given a like a liquid diet, even acute pancreatitis. We know now clear fluids can be started. But if the person is very ill, or the person has bowel obstruction, mm, and also cases you think they need theater, you may be able to you can't give, you have to keep them nil orally as a preparation for surgery. Those cases, of course, you have to give the IV fluids. And for some any condition that person is going to be kept off nutrition for many days, of course you may have to think of other forms of nutrition. But mostly in this acute phase, it's your fluids that you have to be concerned. And sometimes on admission they may be dehydrated, so you may have to replace those fluids. So there are a lot of things to think about. And also this in this symptomatic, like if you have bowel obstruction, it's a good thing to pass the NG, decompress the bowel. So there are many reasons why you have to do that. One thing is that the person gets more comfortable, and also it will give you an idea how much of fluid is now sequestered in the bowel for fluid replacement purposes, and as a preparation for surgery, because if you person go undergo surgery, if the stomach is distended, they can aspirate. Anyway, so final thing, very important thing is whether you need any interventions, which may be either radiological interventions or a surgical intervention. So, like say acute cholecystitis, yes, they will need a cholecystectomy. Acute appendicitis, appendicectomy. Acute pancreatitis, majority are managed conservatively. Perfect peptic ulcer, you need a laparotomy. Tuberous abscess, mostly medical. If they, of course, develop some pelvic abscess, you may have to drain it, ultrasound. Diverticulitis, medical management. When it's a diverticular abscess, you have to consider whether you have to drain it ultrasonically. Uh, but if it's a perforated diverticular disease, diverticulitis or diverticular abscess with peritonitis, then of course you have to operate. Then bowel obstructions, say like adhesive obstruction. Initially you may observe, but bowel obstructed due to a strangulated hernia, or bowel obstructed due to a malignant stricture, they will need surgery. Of course, different disease has its own types of surgery, which you can understand when these systemic pathologies are done separately in clinical surgery. So, but of course, you have to always consider whether they need a intervention, because if the intervention necessary, it has to be, maybe have to done early, otherwise the condition may not improve. Another one I can mention is like acute cholangitis, acute phase to get over, you do a pass a stent. So think various organs and think how acute what are the acute pathologies for organ, and what is the presentation, and each what is the differential diagnosis, and try to rehearse this many times, and take pain in separate regions, take a differential diagnosis, and work out how you're going to make the diagnosis. And also some there these cross references which I have discussed earlier, these acute presentations I have discussed. So it's a good thing that you can revisit and think, see in different regions of the abdomen or different modes of presentations, how to apply this, what the general principles, what we have applied in those situations.